Ischemic heart diseases, synonyms: coronary artery disease, coronary ischemia, or coronary atherosclerosis. Anatomy of the coronary arteries: there are two coronary arteries, left and right, originating from the root of ascending aorta. Left coronary artery, passing forwards to the left in the left atrioventricular groove for a short distance, then divides into anterior descending artery and circumflex artery. Anterior descending artery passing downwards in anterior interventricular groove to the apex and then turns backwards to meet posterior descending artery. Circumflex artery runs posteriorly in the left atrioventricular groove to meet the right coronary. Right coronary artery, it runs in the right atrioventricular groove to the posterior surface of the heart to meet the circumflex artery. Posteriorly, it gives posterior descending artery, which runs in the posterior interventricular groove to meet the anterior descending artery of the left coronary artery. Then we have presentations of ischemic heart disease: asymptomatic, silent, angina, stable or unstable, myocardial infarction, heart failure, shock, arrhythmia, sudden death. Atherosclerosis, condition in which patchy deposits of fatty material, atheromas or atherosclerotic plaques, develop in the walls of medium-sized and large arteries, leading to reduced blood flow. It can cause serious complications such as coronary artery disease, angina, myocardial infarction, and sudden death, cerebrovascular disease, stroke, transient ischemic attack, and peripheral artery disease or erectile dysfunction in men. Risk factors for atherosclerosis: non-modifiable, age, sex, males more than females, positive family history, type A personality. Modifiable: hypertension, causing endothelial damage, hyperglycemia, hyperlipidemia, especially LDL, hyperuricemia, sedentary lifestyle, smoking, and stress. Pathophysiology of the atherosclerosis: response to injury theory. Chronic endothelial injury leads to vascular inflammation and fibroproliferative response. Causes of endothelial injury include LDL cholesterol, infectious agents, Helicobacter pylori, chlamydia pneumonia, toxins, cigarette smoking, hyperglycemia, and vessel wall injury in hypertension. Stable angina pectoris. Definition: it's a clinical syndrome of chest pain due to imbalance between oxygen supply and oxygen demands of the myocardium. Etiology: decreased myocardial oxygen supply or increased myocardial oxygen demand. Decreased supply, whether decrease in quantity or decrease in quality. Decrease in quality, anemia and hypoxia. Decrease in quantity, coronary artery disease or part of low cardiac output disease, such as aortic stenosis and left-sided heart failure. Coronary artery disease, such as coronary atherosclerosis, which is the most common cause, coronary vasculitis, polyarteritis nodosa, Kawasaki, SLE, coronary spasm, coronary embolism, microvascular angina, syndrome X, coronary ostial stenosis of Cephalus, and congenital anomalies. Others, such as amyloidosis, post-transplantation, ionized radiation. Increased myocardial oxygen demand, ventricular hypertrophy, and tachycardia. Clinical picture: clinical pain with 7 criteria: site, character, radiation, duration, precipitating factors, relieving factors, and associations. Chest pain: site, common and the classic presentation is retrosternal. The patient places his clenched hand over the upper sternum. It's compressing and constricting in character, radiating to the left shoulder and inner side of the left arm, up to little finger, neck, jaw, and teeth. Duration less than 15 minutes, usually from 1 to 5 minutes. Less commonly, any side of the chest, scapular, infraclavicular, epigastrium, and the character is squeezing, burning, discomfort, and heaviness. Radiation to the right shoulder, back, epigastric area. Duration more than 15 minutes. But it's never in the left inframammary, and the patient never points with his finger. The character is never stitching or pricking or throbbing. The radiation is never below epigastrium, and the duration is never seconds or hours. Precipitating factors: exercise, sexual intercourse, stress, cold weather, heavy metals, smoking. Many patients report a fixed threshold for angina, which occurs predictably at a certain level of activity. Relieving factors are rest and sublingual nitrates. but occasionally the pain disappears with continued exercise, walk through angina, association, sweating, dizziness, fear of death, dyspnea due to left ventricular failure, eructation at the end of the attack. Silent ischemia is dyspnea, fatigue, and dizziness without pain. Signs during the attack, usually no abnormal finding, a positive Levine sign characterized by patient's fist clenched over the sternum when describing the pain. Pain produced by chest wall pressure is usually of chest wall origin. Pallor, tachycardia, hypertension secondary to sympathetic stimulation. S1 is weak, S2 is reversed splitting, S3 due to left ventricular failure, murmur of mitral regurg due to papillary muscle dysfunction. In between the attacks, physical examination is important to exclude anemia and valvular stenosis. Physical examination of abnormal lipid metabolism, xanthelasma, and or diffuse atherosclerosis, diminished peripheral pulse. Investigations: ECG and echo, dobutamine echo, cardiac sign, coronary angiography, lab investigations. Resting ECG in between the attacks is usually normal, or with ECG of old myocardial infarction. During the attack, we have inverted T wave and depressed ST segment, more than 1 mm. It's depressed except in variant angina. Holter monitoring to detect silent ischemia. Exercise ECG in between the attacks only. The patient exercises on a treadmill with ECG and vital signs being recorded. Stress test can be done with dobutamine in patients unable to do exercise. The stress test is considered positive if one or more changes are present: typical anginal pain during the test, or fall in blood pressure 10 mm mercury or more, because it suggests ischemia, and depressed ST segment more than 1 mm. Exercise test can be misleading as there are false negative results, so normal test doesn't exclude ischemic heart diseases, and false positive results, especially in patients when left ventricular hypertrophy is present. Stress test is contraindicated in acute attacks, severe hypertension, orthopedic problems, congestive heart failure, and severe aortic stenosis. Echo and dobutamine echo show abnormal motion of the myocardium. Cardiac scan, radioactive thallium 201, is taken up by healthy myocardium and not by ischemic myocardium, so it will appear as cold spot. Coronary angiography or coronary catheter to detect the site and severity of coronary occlusion. It's generally used to determine whether mechanical revascularization is possible and to guide the therapy. Lab investigations: cardiac enzymes are normal. For risk factors, blood glucose, plasma lipid, such as cholesterol. Then we have grades of angina by Canadian Cardiovascular Society: 1, 2, 3, 4. 1. No limitation of ordinary activity. 2. Slight limitation of ordinary activity. 3. Marked limitation of ordinary physical activity. 4. Unable to carry on any physical activity without discomfort. Treatment: control risk factors and medical treatment. Coronary revascularization and treatment of the anginal attack. Treatment of the anginal attack by complete rest: nitroglycerin 0.5 mg or isosorbide dinitrate 5 mg sublingually, and repeated up to 3 times successively with interval of 3 minutes. If the patient is not relieved after the use of 2 to 3 tablets, the patient should be immediately transferred to hospital and evaluated for the possibility of myocardial infarction. Control of risk factors by reassurance, sedation, no smoking, treatment of hyperlipidemia, controlling hypertension and diabetes, and changing of lifestyle, regular exercise program. Medical treatment of angina in between the attacks: nitrates, beta blockers, calcium channel blockers, and antiplatelets. Antiplatelets: aspirin, 75 mg single dose. It improves the prognosis. Clopidogrel is expensive. Calcium channel blockers: the action is reduce oxygen demand by negative inotropic action and decreasing afterload. Arteriolar dilators, coronary dilators, increase coronary blood flow, effective in variant angina. Preparations: we have verapamil, great negative inotropic but weak vasodilator, 80 mg 3 times per day. Diltiazem, 60 mg twice daily. Nifedipine, mainly vasodilator and weak negative inotropic, 10 to 20 mg 3 times per day. Recently, amlodipine, mainly vasodilator. Side effects: headache, hypotension, precipitation of heart failure, constipation, peripheral edema, very important MCQ note. Verapamil and diltiazem cause bradycardia and heart block. Then we have beta blockers. It reduces oxygen demand since they reduce heart rate, blood pressure, and contractility. Preparations: we have propranolol, Enral, non-selective beta blocker, atenolol, metoprolol, bisoprolol, they are selective beta blockers, carvedilol, beta blocker with an arterial vasodilating effect. Side effects are bronchospasm, bradycardia, heart block, depression, and impotence. Nitrates: they are venodilators, decrease preload or venous return by decreasing myocardial oxygen demand. Coronary dilatation increases coronary blood flow, mild effect. Preparations: we have nitroglycerin, 2.5 mg twice daily, orally or transdermal patches, isosorbide dinitrate, 10 to 20 mg twice daily, isosorbide mononitrate, 20 to 40 mg twice daily. Side effects: we have headache, hypotension, tolerance, so start with minimal effective dose with nitrate-free interval periods. Then we have coronary revascularization. Indications are angina not responding to medical treatment or post-infarction angina to improve the prognosis. Techniques: we have PTCA, percutaneous transluminal coronary angioplasty, introduction of balloon or stent to dilate the stenotic artery, balloon-tipped catheter. Indications are stenosis of one or two vessels only except left main coronary artery. CABG, coronary artery bypass graft, grafting a piece of saphenous vein or internal mammary artery between the aorta and coronary artery distal to any obstruction. Indications are stenosis of 3 or more vessels, stenosis of left main coronary artery, and for diabetic patients with 2 or 3 vessel disease. Acute coronary syndrome, stable angina, ST elevation myocardial infarction, STEMI, and non-STEMI. Unstable angina. Definition: change in the character of angina by increasing its frequency, severity, or duration. It's considered intermediate syndrome between stable angina and myocardial infarction. The etiology is non-occlusive coronary thrombosis on top of atherosclerosis, recent onset angina, post-myocardial infarction angina, coronary artery spasm, or variant angina. Investigations of unstable angina are ECG, coronary angiography. Cardiac enzymes are not elevated to differentiate it from myocardial infarction. Treatment is to reduce the progression to myocardial infarction. Medical: IV infusion of nitroglycerin, 5 to 10 microgram per minute, and it is raised gradually. Beta blockers: low molecular weight heparin, enoxaparin or Clexane. Antiplatelets: aspirin, clopidogrel. Coronary revascularization, PTCA or CABG. But we need to know what is Prinz-Metal or variant angina or coronary artery spasm. It's caused by spasm of coronary artery with or without atherosclerosis, unpredictable, at rest, showing transient ST elevation. Treatment is nitrate or calcium channel blockers because beta blockers are contraindicated as they increase coronary spasm. Then we have other kinds of angina. Decubitus angina, usually in lying down, occurs in heart failure. Nocturnal angina, it awakens the patient from sleep associated with dreaming. Angina of Lewis, in cases of aortic regurg, because it's nocturnal and prolonged. Then we have acute myocardial infarction. Definition: ischemic necrosis of part of cardiac muscle due to sudden persistent complete cessation of its blood supply. Etiology: thrombosis on top of atherosclerosis or non-atherosclerotic causes of myocardial infarction, such as coronary artery diseases, spasm, dissection, PAN, Takayasu disease, coronary angiography, aortic stenosis, regurg, prolonged hypotension, polycythemia, sickle cell anemia, DIC, TTP, embolism, infective endocarditis, artificial valve, myxoma. Pathology: gross pathology, no changes for 8 to 12 hours, then the area becomes dark. After 24 hours, pale center with normal edges. Microscopic appearance: coagulative necrosis of myocardial tissue, cellular infiltration and inflammatory response. Fibroblasts appear and replacement with fibrous tissue. Classification according to site: Occlusion of the left anterior descending artery lead to anterior infarction. Occlusion of circumflex artery, lateral infarction. Occlusion of right coronary artery, inferior infarction. According to the types, STEMI and non-STEMI. STEMI, transmural infarction, full thickness of the ventricular wall. Subendocardial infarction, non-STEMI, transient or incomplete vessel occlusion. Clinical picture: pain and or complications. Chest pain, similar to angina but more severe. It may be severe enough to be described as the worst pain the patient has ever felt. Radiating more, may be below epigastric area but never below umbilicus. More prolonged, up to several hours. Unrelated to precipitating factors, it may occur at rest, and not relieved by rest or sublingual nitrates. Associations like angina and may be associated with complications. Painless infarction occurs in elderly diabetic neuropathy, patients under anesthesia, and transplanted heart, denervated. Complications: we have early complications and late complications. Early complications include shock, acute heart failure, arrhythmia, myocardial rupture, dry pericarditis, and sudden death. Shock: cardiogenic shock and neurogenic shock. Cardiogenic shock: massive infarction, more than 40% of the cardiac muscle, leading to severe pump failure and high jugular venous pressure. Hypotension, tachycardia, pulmonary edema. The treatment same as acute pulmonary edema and mechanical assist devices such as intra-aortic balloon counterpulsation. Very bad prognosis. Neurogenic shock, good prognosis, treated by morphine. Clinical picture: hypotension and bradycardia. It's caused by severe pain, vagal stimulation. Acute heart failure with normal heart size. Arrhythmia, all types may occur. The most serious are ventricular tachycardia and complete heart block. Myocardial rupture, rupture of the septum, acquired VSD, rupture of papillary muscles, acute mitral regurg, acute heart failure. Rupture of ventricular free wall, blood fills the pericardium, cardiac tamponade. Dry pericarditis, hemorrhagic pericardial effusion may develop especially with thrombolytic therapy. And finally, sudden death due to arrhythmia, ventricular tachycardia, or ventricular fibrillation. Most deaths occur during few hours after myocardial infarction, cardiogenic shock, cardiac rupture, or acute heart failure. Late complications include post-infarction syndrome, post-infarction angina, myocardial aneurysm, thromboembolism, frozen shoulder, and complications of the treatment. Frozen shoulder: stiffness with limitation of movement due to pain from psychic pain or reflex arteriolar spasm and ischemia. Thromboembolism: mural thrombosis, infarction, rough surface thrombosis, systemic emboli, or DVT due to prolonged recumbency leading to pulmonary embolism. Myocardial aneurysm: dilatation of scar tissue of myocardial infarction. On examination, we have double apex. TG shows persistent ST segment elevation, and the fate is refractory heart failure, rupture aneurysm, recurrent embolism, and recurrent arrhythmia. Post-infarction angina due to affection of other diseased coronaries. Post-infarction syndrome or Dressler's syndrome within 4 weeks or more. Autoimmune phenomenon in response to necrotic cardiac tissue characterized by pleurisy, pericarditis, pneumonitis, and fever. Signs: not specific. Physical examination may be entirely normal. Pallor, sweating, nausea, vomiting, fever. Pulse: tachycardia, sympathetic stimulation and cardiogenic shock, bradycardia and neurogenic shock, heart block and inferior myocardial infarction. Irregular arrhythmia, weak left ventricular failure. Bradycardia is usually seen with inferior myocardial infarction because right coronary artery supplies the SA node. Blood pressure, high hypotension in left ventricular shock, failure and shock. Hypertension in sympathetic stimulation. Cardiac auscultation, weak S1, reversed splitting in S2, S3 due to left ventricular failure, S4 due to decreased myocardial compliance, murmur of mitral regurg or VSD, pericardial rub, dry pericarditis, congested neck veins, and right ventricular infarction. Differential diagnosis: causes of acute chest pain, stable and unstable angina, myocardial infarction, pulmonary embolism, aortic dissection, pneumothorax, acute dry pericarditis, cardiac neurosis, esophageal spasm, perforatic peptic ulcer, and cholecystitis. Investigations: we have cardiac enzymes, which differentiated from other kinds of angina: ECG, echocardiography, cardiac scan, coronary angiography, leukocytosis, and increased ESR because there is tissue damage. Cardiac enzymes. They are released into blood from necrotic heart muscle after acute myocardial infarction. Creatine phosphokinase MB, lactic dehydrogenase, troponin, and myoglobin. Creatine phosphokinase, the initial rise 4 to 8 hours, return to normal within 2 to 4 days. It's non-specific because it may rise in damaged skeletal muscle or brain. CPK-MB, 4 to 8 hours initial rise, returns to normal within 2 to 4 days. It's isoenzyme of creatine phosphokinase specific to cardiac muscle. Lactic dehydrogenase, the initial rise is 10 hours, returns to normal 1 to 2 weeks, and it's not specific. Troponin, initial rise is 3 to 12 hours, returns to normal within 1 week. Most sensitive and specific markers of myocardial damage. Myoglobin, initial rise is 1 to 4 hours, returns to normal within 24 hours. ECG, in transmural infarction, STEMI, convex elevation of ST segment, T wave is tall, hyperacute in the first few minutes after vessel occlusion, the earliest change. Later on it's inverted, representing severe ischemia. Finally, pathological Q wave occurs, representing significant myocardial necrosis and replacement by scar tissue. Pathological Q waves, usually defined as duration more than or equal 0.04 seconds or more than 25% of R wave amplitude. In subendocardial infarction, non-STEMI, ST segment is normal or depressed, no pathological Q waves, and T wave is inverted. The ECG may be normal during the first few hours of infarction. In old myocardial infarction, their only residual change is a pathological Q wave. Echocardiography, ventricular wall motion abnormalities, and it shows complications such as mitral regurg, myocardial aneurysm. Cardiac scan, like angina. Coronary angiography reveals which vessels have been affected and the extent of damage. Leukocytosis and increased ESR. Site of infarction as regard to ECG, localization, anterior myocardial infarction, we have ST elevation from V1 to V6. Lateral myocardial infarction, ST elevation in 1 and AVL, V5 and V6. Inferior myocardial infarction, ST elevation in AVF 2 and 3. Diagnosis of myocardial infarction, at least 2 of the following 3 criteria: classic chest pain, ECG changes, positive biomarkers, cardiac enzymes. Treatment, pre-hospital, hospital care. Then we have after discharge. After discharge, aspirin, ACE inhibitors, beta blockers, blood pressure control, cholesterol control, diabetes control and diet, education reassurance, and rehabilitation. Pre-hospital, rapid transfer to hospital is a must. Oxygen inhalation, analgesics for pain, morphine 5 to 10 mg IV. For ventricular arrhythmia, lidocaine 50 to 100 mg IV. For heart block, atropine 0.5 to 1 mg IV. Then we have the hospital care. General, admission to CCU, coronary care unit, with hemodynamic monitoring and continuous ECG, oxygen inhalation, complete rest, diet, light, frequent meals, and avoid constipation, sedatives, diazepam, aspirin, now considered essential elements, 325 mg initial dose, then 75 mg daily, oral, ACE inhibitors, oral therapy, lisinopril, 5 mg on day 1 and 2, then 10 mg daily, administration of IV fluids in hypotension. ACE inhibitors are vasodilators which reduce cardiac work and decrease myocardial energy requirement, but they also have inhibitory effect on the cardiac remodeling. Relieving of chest pain, morphine 4 mg IV every 5 to 10 minutes as needed, nitroglycerin and beta blockers to relieve pain of post-infarction angina. Thrombolytic therapy. The earlier the thrombolytic therapy is given after the onset of chest pain, the greater the benefit. Thrombolytic therapy is beneficial up to 6 hours but may be given for up to 12 hours. Streptokinase 1.5 million units IV over 60 minutes may cause allergy. urokinase, altiplase, tissue plasminogen activator. The most important issue in thrombolytic therapy is not which drug to use, but how quickly to use it. Anticoagulant, heparin, antiplatelet, aspirin are given with and after the thrombolytic therapy to reduce the risk of re-occlusion. The major risk factor is bleeding. Contraindications: bleeding disorders, major surgery within past 2 weeks, recent cerebral hemorrhage within past 12 months, active internal bleeding, peptic ulcer, severe hypertension, diabetic retinopathy with recent bleeding, aortic dissection, and pericarditis. Angioplasty, percutaneous transluminal coronary angioplasty, PTCA, introduction of balloon or stent to dilate the stenotic artery, more effective than thrombolytic therapy because it's of fewer complications and shorter hospitalization. Treatment of early complications such as acute heart failure, arrhythmia, and cardiogenic shock. And this concludes our chapter for today.